sorry, I will speak English. And first of all, I would like to thank everybody, including the organizers, to still keeping going, inviting me, because last year I was supposed to come here, but then at the very end, I was even at the airport, and I was not able to come. So I was very, very sorry for this problem. So anyway, I'm here today, and my task is to start speaking about facial lesions, which is, by the way, the most difficult part of our job. So it will be very, very difficult for me. So let's do it very practical, okay? Very, very practical. So this is our scenario, okay? A fancy lady is coming to our office, and she wants to remove this spot here. Huh? It's here. Look how fancy is my, yeah? This is very nice, huh? Okay, so what should we do? Yeah? Should we, what do you like to do with this little black spot? Dermoscopy. Ah, you don't go with cryo. I like cryo. I like very much cryo. Look how magic is cryotherapy. It's giving a great impression to our patients. Yeah. Okay, but I agree with you. It's better to look at the lesion before. Yeah. Because the problem is that melanoma on the face is extremely difficult. It could be extremely difficult. So that's the lesion, and that's the dermoscopy. So now, what should we do? Yeah, I mean, this is a quite new lesion, maybe a few months, 6 months, not more. Ah, you say biopsy. Ah, yeah. Okay, let's say so. It's not very easy, you know, because, I mean, we have some kind of brown color, maybe a little bit of gray color, especially in this couple of parts here, but I mean, there is not so much, you know. So I'm very unsure what to do with this lesion. Okay, come on, this is a small lesion. So let's say so. I don't give you the solution now. We come to the solution in 5 minutes. Okay. So first of all, my changing mind with melanoma on the face is due to a couple of things. First of all, okay. Usually in my mind, facial melanoma is connected to an old patient, okay? So 75, 80, okay. And this is the case here, yeah? This is the prototype of lentigo malignant melanoma, okay? Old patient, big lesion like this, okay. But now the question is, what do you think, how long ago this lesion was starting to become like this? 20 years. Yes, 20 years, even more. Okay, so we have to start to understand, to keep in our mind that the very early melanoma on the face is not found in a 70-year-old lady, but in a 45-year-old lady, 50-year-old lady. Okay, so this is the first concept. Second concept. The main dermoscopic criterion that I have to look for in lentigo maligna on the face is the gray color, okay? Whenever I see gray color on the face, I have to stop, yeah, and to decide if I have to wait a little bit, make a picture, and then make a follow-up or a biopsy, okay? So these are the two things we have to remind in our brain. So basically, this is a 45-year-old man coming with a single lesion on his face, is fat. So then, this is the lesion I have to look with dermoscopy. And when I see it dermoscopically, yeah, don't you think that this is gray color? Yes. So this is the reason why I have to stop and I have to say, look, this is a lesion that it could be benign, it could be suspicious, so certainly we cannot burn it, yeah? So either we wait a little bit or we make a biopsy, okay? So these are the two principles, okay? So now I want to go immediately to the problem, okay? Of course, this is a very good principle. Gray color, biopsy, no gray color, whatever you do, okay? Whatever you like. But the problem is that in very early lentigo maligna on the face, and this is a lentigo maligna, can you imagine? We don't actually see even the gray color, yeah? Because, I mean, gray color here, I don't know, yeah? It's extremely difficult. So how to solve this problem, yeah? How to solve this problem? Well, it's been already now a couple of years that I changed completely the way I do when dealing with facial lesions. I don't look first for gray color, but what I do, I look first for benign features. If I find benign features, then I'm completely sure this is a benign lesion. If I don't find benign features, then also I have to stop and I have to think what to do, okay? So let's review a little bit the benign features. These are the benign features that I have to look for when I see, when I evaluate lesions on the face, okay? Scales, white follicles or rosettes, erythema or reticular vessels, reticular lines or fingerprints, structureless brown color, sharp demarcation at the periphery, and classic seborrheic keratosis criteria, okay? This is what I have to look for. Of course, the first 1, 2, 3, these are criteria that I mainly find in what? In actinic keratosis, in pigmented actinic keratosis of the face. We will speak about it also later on. But certainly, these are criteria associated with actinic keratosis. And this is the point. What is my differential diagnosis on the face? On one side is melanoma. On the other side, we have two lesions, pigmented actinic keratosis and solar lentigos, okay? On the side of the benign lesions. Of course, pigmented actinic keratosis is a kind of benign lesion. It's not completely benign, but still, we consider it benign as compared to melanoma, okay? And then the method is very, very easy. If I find a prevalent benign pattern, then I consider the lesion benign. If I don't find a prevalent benign pattern, I consider the lesion suspicious. That's it, okay? Now, what are the criteria? Look how bad is this lesion clinically, yeah? It's very irregular. But mainly, what I see is this kind of structures here. What is this? This is pigmented scales, okay? So, for sure, melanoma is not showing pigmented scales. There are no scales in melanoma, okay? So, pigmented scales are usually associated with pigmented actinic keratosis, okay? I see also another criterion here, and these are this kind of white follicles, yeah? White follicles. It's full of these whitish, very evident follicles, and this is another criterion for pigmented actinic keratosis. So, this is the main criteria here, and even if I find a little bit of gray color, I don't care, yeah? Because the predominant features are benign, okay? Now, another lesion. This is on the nose, yeah? And here, what I see, how can you, rosettes, exactly. So when I see many rosettes, yeah, again, I have to think about pigmented actinic keratosis. Here, I find also non-pigmented scales, okay? So scales plus a lot of rosettes. Rosettes are these 4 dots into the follicle, okay? So then again, prevalent benign features. Also, there is another feature here. What? Background erythema. The lesion is red, okay? So predominant benign features, I can do cryo, I can do laser, I can do whatever, you know? I'm sure this is a benign lesion. By the way, this is the same lesion, this is a pigmented actinic keratosis, pictured, photographed on this side with a standard dermoscopy, non-polarized dermoscopy, and on the other side, polarized thermoscopy. So when I use polarized thermoscopy, I see rosettes. You see the 4 dots? Yeah? The 4 dots. But when I see the same lesion with non-polarized thermoscopy, I don't see rosettes anymore. I see these kind of white follicles, yeah? As you can see here. Very, very evident, okay? So here again, erythema, white follicles, rosettes, and what? What are they? Scales, exactly, perfect. So, plenty of benign features. I can do cryo, okay? Of course, this is very easy. Reticular vessels, okay? So this is actinic keratosis, yeah? Now, we move to the criteria of solar lentigo. Look at this lesion, it's horrible. It's horrible clinically. But if I see this sharp demarcation at the periphery, come on, this must be solar lentigo. Yeah? If I see this kind of fingerprinting or classic network, you know, these parallel lines, yeah? This is really, really very specific for solar lentigo. Sharp demarcation, fingerprinting, reticular network. This is very pretty much in line with solar lentigo, okay? Again, reticular lines. This is a solar lentigo. Okay, and here, look at the other side. We have also this criterion, which is more rare: brownish pigmentation. You know, homogeneous, structureless brownish pigmentation. This is also in line with solar lentigo, and sharp demarcation at the periphery. Okay, so again, I'm on the safe side. I can treat these lesions, and finally. In this lesion, which is ugly from a clinical point of view, but I see what? Milia, yeah? You know that, sorry? Yeah, oh, yeah, of course. Yes, that's the point. That's the point. If we first look for the malignant criteria, then we see a lot of, yeah, it's disturbing because this is a circle, and this is circle. But if I look first for the benign features, I feel more confident. And if I see lots of milia in this side, and lots of fingerprinting, you know, these parallel lines, yeah, then I know that the prevalent features are benign, so I am on the safe side. This is just a solar lentigo. Okay, so on the face, we have to do the opposite as we do for the rest of the body. Instead of looking for malignant criteria, let's look first for the benign criteria. Okay, so now this is the point. Okay, I have to evaluate a lesion on the face. So first, benign features. Do I see benign features here? Yeah? Yes or no? Yes. Reticulation, exactly. Predominant reticulation, so this is benign. Is there a little bit of gray color? Yes, but the predominant feature is benign, so I'm dealing with the solar lentigo. Here, what kind of benign features can I see here? Sharp demarcation, reticulation? Not really, no? Scales, yes, a little bit. Is this predominant? Not really, yeah? Not really. I don't see clear-cut benign features here. And that's why first I have to stop and think. Do I see gray color? Yes, a little bit. Okay, so now I know that this is a lesion I have to deal with a biopsy or with follow-up. And this was melanoma. Yeah, but these white circles are not really so evident like we saw before. I will show you some more cases to exercise our brain, okay? Let's look at this other lesion here, okay? It's a small lesion in a young lady, by the way, okay? But she is 40, yeah? So in the age we have to consider, right? Okay. Now, do we see benign features here? Benign features? Reticulation, sharp demarcation, fingerprinting, not really, right? So, stop, yeah? We don't do cryo, okay? Do we see malignant features? Well, a little bit of circles, but it's not very easy to look for malignant features. So, but I'm sure that there are no benign features here. And this is melanoma. Can you imagine? Yeah? So if we use this method, these are the numbers we can reach. 90% sensitivity, 70 more or less percent specificity. It's not so high, but still. Okay. Benign or malignant? Benign. What's that? Scales, pigmented scales. Look at the white follicles. These are white follicles, really white. They should be white, yeah? And erythema. So we have plenty of benign features. Pigmented actinic keratosis. Benign or malignant? It looks malignant, right? But do you see benign features? No? Sure? What are they? Rosettes, plenty of rosettes, plenty. And you have also erythema. So despite the fact that this is really ugly, this is just a pigmented actinic keratosis. Yeah, exactly, exactly. Benign or malignant? Benign, yes. What are they? Pigmented actinic, sorry. Okay. Look, you see pigmented scales, white follicles, and even if there is a little bit of gray, yeah. The predominant features are benign. That's why we can think about the pigmented actinic keratosis. Benign or malignant? Benign. Actinic keratosis, reticular vessels. Benign or malignant? Benign. Fingerprinting. No? Perfect. Okay. Benign or malignant? Benign. Very good. Fingerprinting. Plenty of fingerprinting. And white follicles. And sharp demarcation. Exactly. Yeah. Benign or malignant? Benign. Reticulation. Okay. We can do cryo. Benign or malignant? Benign. Perfect. Reticulation. Look. Reticulation. Fingerprinting. Parallel lines. Sharp demarcation. Moth-eaten border. You know, this kind of like a, this is also a nice criterion for solar lentigo. It's like a bite in a sandwich. Yeah? Moth-eaten border. Okay? Benign or malignant? Benign. Very good. What? Sharp demarcation. Moth-eaten border. Yeah? So this is benign. Okay, so let's go back to our lady. So now, benign features here? Not really, exactly. So now, first point, no benign features. No clearly evident benign features. Do I see some gray color? Yes. Yes, a little bit of gray color. So I have two reasons why I have to stop. And certainly I don't do a cryo. In this case, we did a biopsy, yeah? But we could also say to the lady, come back in 3-6 months. There is no worry, you know, because this is a very slow-growing lesion. So you can follow up a lesion like this, but with the picture, because then you can see the difference, okay? But in this case, we did a biopsy. And you know what was the result histologically? This is also very important, yeah? We have to keep in mind that with a small biopsy, the pathologist sometimes cannot tell you that this is melanoma, yeah? But he is telling you anyhow some important information, because in this case, his diagnosis was junctional nevus. Could it be possible that this is a junctional nevus? Come on, no way. No way. This is too old to have a junctional nevus on the face. A child can have a junctional nevus on the face, but then, during age, nevi are becoming dermal. Yeah, so we have dermal nevi on the face, okay? Remember that our differential diagnosis on the face is between melanoma and non-melanocytic lesions. Non-melanocytic. solar lentigo, and pigmented actinic keratosis. So if he sees a nevus, it means that this is a melanoma. And in fact, we then excised the entire lesion, and then the diagnosis was melanoma in situ. Okay? Extremely important. Yeah. So now, let's review some more cases. This is a small lesion. She's 55. Benign features? Benign? Which kind of benign features you see? White? They are not so white. Let me tell you, not so white. Yeah? Not so white. Not really. Is the margin demarcated? Not really. Do you see any fingerprinting? Not really. No? Scales, yeah, okay, maybe a little bit, but it's too small, you know, it's not prevalent. So I don't see prevalent benign features here. So I feel unsure. Yeah? And there is a little bit of gray color. Do you agree? Gray color. So this is a melanoma. Now, this is ugly. Okay. Benign or malignant? Benign. Perfect. What? White follicles. Look, they are white. Really white. Yeah? Sharp demarcation at the periphery. Is there a gray color? Yes, but the prevalent features are benign. So this is pigmented actinic keratosis. This is a quite pigmented lesion here. Not so easy in my view. Because the point is, I can see the benign features. What are the benign features? Here. Yeah? Reticulation. But now the question is, are they prevalent? That's the point. They are not prevalent. They are just on one side of the lesion here. What is prevalent here? The malignant features. Too much gray. Yeah? So we don't have to think that if we see a little bit of benign features, it's benign. Because we can have a mixture. Here we had a solar lentigo associated with a melanoma. Okay. Yeah. Now, benign or suspicious? Suspicious. Why? No benign features. Yeah, no benign features. And a little bit of gray color here. Gray color. Yeah? So, melanoma. Very good job. Benign or suspicious? Benign. Perfetto. I see that you got it. Benign or suspicious? Do you see benign features? No. Perfetto. That's it. Melanoma. This is recurrent melanoma. I can tell you, you see the scar. Do you see the scar? Yeah? So this is a lesion which was removed previously, and the diagnosis histologically was junctional nevus. And then the clinician didn't remove everything, and the lesion is recurring because this is not a nevus, this is a melanoma. Okay. Again, you can see the scar. Yeah? We have plenty of these cases. Yeah? You see the scar. The lesion was previously diagnosed as a junctional nevus. Then the patient comes to me. I already know that there is something wrong here. Junctional nevus. Then I look dermoscopically, and to the question, do I see benign features? Well, not really, not really, not really. So I see a very regularly pigmented lesion, not too much, non-benign features, no malignant features. I don't see I see almost anything, but based on the previous history of a junctional nevus, histological, we had to remove this lesion, and this was melanoma. Okay, and then another one, yeah? You see, there is a scar here, and again the same story, yeah? Junctional nevus histologically, and then melanoma, yeah? Yeah, the gray dots and stuff like this. So we have to be, so in conclusion, face, it's a little bit difficult, really, it's difficult, yeah? This is the area where I missed the great majority of the melanomas that I missed in my life, okay? But we have to be optimistic. First, because melanoma on the face is extremely slow, okay? There is plenty of time to diagnose this melanoma, okay? So this is a good point. Can you imagine that this lady was diagnosed with a melanoma in the age of 51, and this is a clear-cut melanoma. But can you imagine when she was 30, yeah, the lesion was already there, yeah, 20 years ago. And I'm not sure when she was 22, the lesion was there, I don't know, but certainly is there when she was 30. So it's extremely slow growing. So this is a good point. And nowadays we have more ways to diagnose these melanomas. The important thing is that we have to understand when to stop and not to do the cryo, okay? That's the most important thing. So whenever we are doubtful, let's stop and think about follow-up or biopsy. Thank you.
Thank you. Je voudrais juste rajouter une chose, c'est que normalement, comme l'a bien précisé professeur Argenziano, concernant le dubreuil, ça évolue lentement. Notre problématique actuelle, c'est que nous avons à notre disposition des moyens de traitement esthétique sans laisser de cicatrices. Ce qui fait, si on ne sait pas quand est-ce qu'on doit s'arrêter, alors cette évolution lente sur des années ne va plus se voir. C'est ça la problématique. Mais si on le laisse, il va évoluer lentement sans problème. Le problème, c'est quand on le traite par cryo ou par laser. C'est là la difficulté. Et donc, il faut savoir dire à vos patients non. Non. Ou alors, je vous fais la biopsie. Il ne faut pas avoir cette peur, car cette évolution, et on va la voir tout à l'heure en fin de journée, ça porte vraiment une évolution plus rapide. I see that the evolution for lentigo maligna, it's very slow, but if we treat it by laser or cryotherapy, it may be more fast for the evolution of the disease.
I agree completely. I agree.
So you must to be very careful about this.